Welcome to the orthoPAC podcast with your hosts Sam Dyer, Chuck Dowell, and Miles Gilbreth. Please join us as we attempt to fill in the gaps between education, current events, and real-world practice. Today we have myself, Chuck, and Miles. Let's welcome Vanessa Smith. Vanessa is a PA who specializes in hand and wrist, and we're having her on today to talk about trigger fingers.
In our office, I know it's not caught on yet around the country, but very commonly in Canada and some other places is to do these trigger finger releases under local anesthesia in the office with the patient wide awake. So we're using lidocaine with epinephrine in the fingers. Yes, you heard me. Epinephrine can be used in the fingers and hand. That old saying has been disproven with level 1 evidence that epinephrine is safe in the fingers. So we're using lidocaine with epinephrine. The patient is wide awake. They're listening to music. Maybe they have a virtual reality headset on. They've had breakfast. They've taken all their morning medications, and they're having their trigger finger released in the office in the procedure room. While they're there, then we can show them their tendon. We'll ask them, do you want to see your tendon? And we'll put the blue drape down a little bit so they can see that tendon moving, and they can see that their motion is already better. But some folks don't want to see it. So we just bandage it up and then have them kind of sit up, make sure they're not lightheaded or anything, and then they walk out and drive home. So trigger finger surgery is much less invasive, I should say, can be much less invasive and as big of a deal and cost than it used to be.
So the trigger finger release, you do it with local whatnot. I mean, it can't be much worse than the Xiaflex and the Dupotrons. I mean, that's pretty brutal when you release that. So I don't think patients would have as much of a trouble. Lido with epi, I mean, that's so beaten into our heads, fingers, nose, penis, and toes, right?
Yep.
You're not supposed to inject those. It's not an off-label thing to do that. I know you said there's a lot of evidence, level 1 evidence, I think you said that has it. Now, you're a hand specialist and you're working with a hand surgeon. What about Joe Smith, who's out in rural whatever, that only has Lido with epi?
Okay.
Are there limitations on how much you should use? Because if there's a potential complication with that, you're kind of holding it back there, aren't you?
So the key is you're not using a lot. I have a talk on YouTube that's regarding digital blocks and the use of lidocaine with epinephrine. And I referenced Dr. Lalonde's work. He's out of Canada, and numerous articles that he has published about the safety and efficacy of lidocaine with epinephrine. Historically, what caused digit necrosis was not the epinephrine, but the acidity of the lidocaine, which was actually closer to cocaine. This lidocaine that had sat on the shelf, that was the issue. It wasn't the epinephrine. And so they've used it over and over, and it's being widely used in hand surgery, lidocaine with epinephrine, but it's not boatloads. So in order to do a digital block, let's say we're talking about the long finger. There's a technique that Dr. Lalonde has termed simple: subcutaneous injection, midline, proximal phalanx, lidocaine with epinephrine. You have your palm face up. You have your injection ready, and you're going to administer 2 ml of lidocaine with epinephrine. You can buffer that with bicarb, because bicarb's a little more basic than the lidocaine, but people also tolerate it without the bicarb. But you're going to just poke midline, proximal phalanx of that long finger, sub-Q. Don't move your needle. Don't go looking for those digital nerves. That is pure torture for the patient. I can't tell you how many people have come from the ER or surrounding acute cares, and they don't want to see another needle with how much pain they were caused from a digital block. So you cause less pain, and you still get an effective block. And this is all kind of reviewed at length. It's about a 17-minute talk. But the idea is when you go sub-Q and you put in 2 ml Lido with epinephrine, that medicine diffuses to both the radial and ulnar digital nerves in that area. And because those nerves are numb, you now have a numb fingertip. That area has been blocked because of your injection over the proximal phalanx. So to get a full digital block, then we would go 2 ml lidocaine with epinephrine volar, then flip them over, 2 ml Lido with epi dorsal over that proximal phalanx midline. Don't move your needle. Just go sub-Q. I feel like this is it's just such a simple thing, and it's so effective. The key is you got to let it set for 20 minutes. You can't, it doesn't just affect immediately. So you do the block, you let it sit there for 20 minutes, then you come and address the rest, whether it's a finger crush injury or nail bed laceration or something like that, letting it set up. If you're going to use lidocaine with epinephrine, the antagonist of it is phentolamine. So you would want to have phentolamine on hand, okay? So epinephrine is a vasoconstrictor. Phentolamine then is a vasodilator. I would say out of the hundreds of times we use lidocaine with epinephrine in a year, there's maybe 1 or 2 times that we need to use phentolamine. And we determine that based on, before they leave, then, that the fingertip it might be a little white, but it's starting to pink back up. But let's say if it's not, it's white and it's really white and it's not starting to lose any of that that vasoconstriction, or what's called vasospasm, then we will inject phentolamine. And so that's a powder. You mix it with sterile saline and you inject it at the site that you injected the lidocaine. So you don't go up at the fingertip. You put it where that lido with epinephrine, where that was taking effect. So you do it at over that proximal phalanx, both volar and dorsal. And that will relax the vasospasm of those digital vessels to allow perfusion again. But again, it's very rare. But I would say if you're going to use lidocaine with epinephrine, then you should have phentolamine on hand, have it available. And might I add, if you're addressing a crush injury of a fingertip or fingernail, please use absorbable suture. Please, 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 for the love of all things, use absorbable suture. Taking nylon or proline out of a finger that has been crushed is torture for the patient and for me, taking the stitches out. So unless it's a clean cut laceration, do not use proline or nylon. Use absorbable.
Yeah, it's no problem.
Yeah.
No problem for me, but my medical assistant complains quite a bit. No, I agree. I totally agree. Don't like to yank those out of anybody's fingers. Hey, you know what? We're running short on time, so let's get final thoughts. Chuck and Miles, do you have any questions or comments or thoughts for Vanessa?
Yeah, so I wanted to go back to your digital block. And obviously, you could, if you don't have phentolamine, you can do it with plain. So you said distal palmar crease, correct?
Proximal phalanx.
Proximal phalanx. Okay.
So just distal to the distal palmar crease, just kind of right.
Yeah, right in that spot. And that's where I do it. And so you're saying just 2 cc's under the skin, flip it over, same proximal phalanx, 2 cc's under the skin dorsally.
You got it.
Your approach. Okay.
Got it.
Yeah, I typically just do 3 cc's over the palmar aspect, and I haven't really had much issues with incomplete anesthesia. I know our hand specialists that cover the ER that I work at they're more in favor of an even more palmar approach. So maybe the I don't even know what you would call it.
Well, at the level of A1 pulley, you could inject it there. Same concept. You're going to get the radial and ulnar digital nerves to long finger. Yeah. And so yeah.
I think they go even further palmar than the A1 pulley, and they do like 6 cc's or so. And they get a much broader area of anesthesia.
Right.
I personally don't like it. I still go at that MCP area, but I've never done it dorsal. I just do the one approach palmar.
Mm-hmm.
So
I just think about that radial nerve. I think about the innervation from the radial nerve distribution. And so if there's any radial nerve fibers heading up to where I'm working, I know the median nerve also covers that area, then I know I've got it covered. I remember a patient coming in from the ER that had a thumbnail laceration from a crush injury. And he said he got poked like a pincushion. He got poked on the dorsal thumb, over the proximal phalanx, over the distal phalanx, in the wound itself. He got poked so many times, and he said, I can still feel you. Just stop poking me and suture it up. I asked him, did they ever poke volar? And he said, no.
Oh.
So it's just understanding of the anatomy, right? Like we've got that radial nerve distribution on the dorsal radial aspect of the hand, but then we've got the median nerve. So I just find, just to be sure we've got all nerve endings covered, I do both. But
fair enough.
Mm-hmm.
And 2 cc's of each site.
Yeah, 2 to 3 ml. Like I think Dr. Lalonde's research talks more about 2 ml of lido with epinephrine. because of how well that epinephrine helps. That's plenty.
Yeah, thanks for all your interesting information you provided today.
You're welcome.
Yeah, and I think before Chuck comes on, letting the patient sit there and percolate for a while. I mean, if you've ever had an injection in your hand, you become tachycardic because it's not much fun to get a shot in your hand. So, if you're tachycardic and you're jacked up and you're already sore from, crushing injury or whatever, it's just going to take some time for the local to work. So give your block some time before you go and say, oh, it's been 2 minutes. Let's try something else. Or, oh, let me pull your nail off. It's been 2 minutes. Yeah, they give you a
Right.
little bit of time to work. That's super important. And I'm glad you mentioned that, Vanessa.
The other thing I might add is that epinephrine can make people feel jittery. So give them a heads up that nothing is wrong, that can be a side effect of the epinephrine. If they have Raynaud's disease or they have peripheral vascular disease, then we would not want to use the epinephrine, right? We've already got compromised vasculature. So those would be some cases where we wouldn't want to use Lido with epi.
I thought that was great. Thank you, Vanessa. I would agree. Anecdotally, I just had a thumbnail avulsion come in that had been treated in the ER and the urgent care, poked multiple times, didn't have complete anesthesia, and kind of the same thing as Vanessa said. They were all doing volar Palmer blocks, and I did a dorsal block on her and was able to get complete anesthesia and remove the nail. And for me, I think those are the nail in the nail bed has been the one that the dorsal block has been the most important with. I seem to miss that with the volar block or the Palmer block. I don't know what your experience with it is, Vanessa, but that's usually when I'm always going dorsally as well when I have the nail bed or nail involved.
Yep, absolutely. Yep, volar and dorsal.
And then I thought was interesting was the trigger finger. I see locked trigger fingers in the orthopedic urgent care all the time. When you see those, Vanessa, just anecdotally from my information, do you just anesthetize them and unlock it and then splint them? Or do you also do a cortisone injection for, let's say, treatment for the trigger finger as well?
Like it's locked in flexion. They can't get it out straight. I think a cortisone with the lidocaine will probably loosen it up. Probably one thing to think about is that if you are then unlocking it, put the wrist in flexion. That will take the flexor tendons put them on slack versus having the wrists completely extended on the table and you're trying to straighten a tendon that's already tight. So that might also help too once you administer an injection then in the palm at the A1 pulley. Put that wrist in flexion to put the finger flexors on slack and then to attempt to straighten it. And then I'd probably have them follow up in a couple of weeks with a hand surgeon to make sure they haven't had continued, usually 2 to 3 weeks, continued locking. But if they have and it's locked again, then they probably would do a surgery. Because sometimes the surgery isn't just an opening of the A1 pulley. It's an opening of the A1 pulley and an excision of a slip of FDS tendon. So you're making that flexor tendon less bulky so it can travel through those pulleys better. So some folks need that from the get-go based on what they find intraoperatively.
Well, I just got to say that's a super great pearl to flex the wrist before you try to reduce the finger. And I have to admit that I usually, if somebody came in with that, I just pop it back out straight and then put a splint or something on it. But that's great. I mean, holding the wrist in flexion, that's really good.
That goes with reducing PIP joints as well, like dislocations. Our finger flexors are so strong and so tight. And if you have the wrist extended, if you're not even paying attention to the wrist and you're just focused on the finger, you're going to be kind of fighting their anatomy, so to speak, to try to reduce that PIP joint. So by putting the wrist in flexion, you put all those strong muscles on some slack and you'll have better results of trying to reduce the dislocation.
Great information. That's great information. Well, Vanessa, I want to thank you for coming on today. A lot of good information, for our primary care colleagues. So Vanessa, I really appreciate your time today.
Wonderful. Thank you so much.
Please follow the Physician Assistants in Orthopedic Surgery on social media. Please subscribe to our podcast. If this has been helpful, please take a moment to leave a review.